All right, well, I just came back from Mexico City where I had the good fortune to be able to speak to the Mexican Society of Plastic Surgeons, an international audience, about one of the techniques I use to bring about shape in deep plane facelifts in my triangle maximizing, my TriMax deep plane facelift. So if you think about it, a facelift really needs to focus not just on lifting, but on creating shape. And the shapes that we create have to enhance contours. One of the contours that we're trying to really bring about in the face to restore youth and a beautiful appearance is a double ogee curve. What's an ogee curve? First of all, an ogee curve is an architectural term that describes where a convexity meets a concavity, a valley meets a small mountain. In the face, we're seeking a double ogee curve. I'm going to show that in a second here. Okay, so the ogee curve that's a double one in the face that we seek to create with the deep plane facelift is where we have a convexity, a mound at the malar eminence, a submalar hollow, so a little hollow in that region. We want to see a little bit of fullness once again in the gonadal angle, and then in that cervical mandibular region, we want to have a hollowness there. Here is a good example of a patient, and especially when we look in the oblique view and we see what was brought about by the facelift, you can see fullness here, subtle hollowness there, fullness there, subtle hollowness there. Look at that nice shadow. Now, how do we bring about that? I use 5 sutures, 5 key sutures in my deep plane facelift. 4 of them are key suspension sutures. The final one is just a securing suture that ties everything together. Those 5 sutures are used to help create that shape. The 4 that are the vector-oriented sutures are S1, S2, P1, and P2. S1 and S2 refer to SMAS. That in the deep plane facelift is anchoring to that SMAS tissue, that very important tissue that helps hold the soft tissues in place. And then the platysma is the thin muscle in the neck. And those sutures alternate in their vector. SMAS 1 is mostly vertical. SMAS 2 is somewhat horizontal and oblique. Platysma 1 is up again, vertical. And then platysma 2 is oblique and horizontal once again. Let's dive a little bit deeper when we're thinking about S1 and S2. S1, that SMAS suture, the first one, it's the first suture to be placed, and we place that at the midpoint between the eye and the tragus, and what that does is that helps push up some of the soft tissue onto the cheek, and it's anchored to the deep temporal fascia just in front of, just anterior to the sideburn. Now after that one locks that cheek tissue in place, creates more malar enhancement, we want to create that hollow. We don't go vertical anymore for SMAS 2. What we do is we go a vector that's different, horizontal and oblique, and we anchor it to the deep temporal fascia just behind that sideburn. You can see that in these tissues here where this white stuff is the fascia, that deep temporal fascia, and where that black line is, that's where the SMAS, where that deep plane was initially entered. And what the yellow represents is how we pull that tissue up, and again, we secure it. Now, that first suture, as I said, is located about halfway from the malar eminence, or it could be the eye, to the ear or the tragus region. And it's by placing that suture halfway between, when we pull up, when we go vertical, vertical oblique, it helps create a little bit of a fullness there by stacking some of that tissue in the malar eminence to enhance that malar mound. Now, when we move on to do SMAS 2, remember, that's a suture where the vector is going to be different from SMAS 1. By making that vector a little bit more horizontal than SMAS 1, SMAS 2 almost pulls tissue out of that submalar hollow, creating a nice, attractive shadow there. And that gives us our first ogee curve. Now, one thing you may worry about is that this vector here, it goes from the corner of the mouth to the posterior portion of the sideburn, the upper part of the ear. You may be wondering, will that pull the mouth out, the corner of the mouth out, creating a wider smile? And the answer to that is no. And the reason for that is that first vertical suture really anchors the tissue from where that suture has secured it it anchors everything this way. And the pull, that redistribution of tissue from SMAS 2 is located in the posterior portion of the cheek, therefore not really pulling on the mouth. And you can see how in this particular patient, we got a nice enhancement of the fullness here. And we also got a subtle shadow, which we'll see on her oblique view in the submalar hollow region. Let's go on to talk about the platysma. Now the platysma has platysma 1 and platysma 2 sutures. Again, vertical and a little bit more horizontal. That vertical suture takes the upper part of the platysma, wraps it around the gonial angle, and pushes a little bit of tissue up onto it to enhance that gonial angle. The gonial angle is the back part of the mandible. And then anchors it to deep tissue behind the ear and securing it to the mastoid here. So it's vertical to the ear, wraps around, and then secures it to the mastoid. Platysma 2 goes almost straight back. So again, platysma 1, enhancing the gonial angle. Platysma 2 is pulling tissue out of the cervicomandibular angle break point, creating a nice hollow there, defining the jaw. I want to talk a little bit more about platysma 1. Remember, that's a stair-step suture, and what that does is it helps bring the upper part of the platysma up, wrapping it around the gonial angle, creating good definition to the jaw, and in particular, the angle of the jaw. Platysma 2, again, remember, it pulls the tissue out of the cervicomandibular angle, creating a nice hollowness there, a hollowness in a good way, and that creates the second ogee curve. So remember, fullness, hollow, comes from lift, pull, and the vectors, with those different vectors, it's really bringing about that shape that we're looking for. We secure everything in place by doing a security and smoothing suture. It just holds everything in place, smooths out the deeper plane, and gives a really beautiful natural result. Here's that last example of a patient where you can see really good definition of the gonial angle. Before surgery, it was hard to see because it was buried in the soft tissue. Afterwards, you can see an improvement in the gonial angle. Not really present, much better defined. Much better defined. Well, there we are. Hope you learned something.